Hello all, this is Miss Gibson. So now we're going to move on to tumors of the urinary system. This is your objectives. So renal tumors, they're classified as benign or malignant, primary or metastasis. So if you hear nurses say, they have cancer that has metsed, all that means is that the cancer started in one place, maybe the liver, and now it has moved to the lung. Benign is usually only found on autopsy. The 11th leading cause of cancer deaths in the United States is from renal tumors, and it is the 8th most common type of cancer. Primary renal tumors are usually renal cell carcinomas. They develop unilaterally, often large when detected. A renal mass or tumor is just an abnormal growth of tissue in the kidneys. Some renal masses are benign or non-cancerous. Some are cancerous, of course. 1 in 4 renal masses are benign. Smaller masses are more likely to be benign, where your larger ones are more likely to be cancerous. You do need to know that Mets lesions are more likely to occur with lung, breast, and melanoma, as well as some lymphomas. That's very important. So some risk factors: smoking, male, high blood pressure, end-stage renal disease, or history of dialysis use can cause the renal cancer. Some of your clinical manifestations: hematuria, flank pain, frequent UTIs, weight loss, loss of appetite, a lot of swelling in the bilateral lower extremities, and blood in the urine or hematuria, which I think I've already said. Tumor stages. So tumors are staged 1 to 4, and it's T1, T2, T3, T4. T4 will spread outside of the kidney. Your ones are usually confined, and as they get bigger, then they will move outside of the kidney. Stage 1, there's usually a 5-year survival rate of 81%. Your stage 4, because it's going to mets, is a 5-year survival rate of only 8%. Some of your diagnostics testing, I'm not going to go over these. I've discussed them a lot. The one thing that I haven't discussed is this needle biopsy, where they would go straight into the kidney, into the mass. They would obtain a small little piece of the mass, and they'll send it off for testing. Some medical management: radical nephrectomy, which is removal of the kidney. It could be removal of the adrenal glands, which sit on top of the kidney, muscle, fat, even the lymph nodes. There is no effective treatment for cancer with meds. Disease may reoccur more than 15 years after removal of the original primary lesion. Really, really sad. Some nursing interventions. I'm going to let you guys look over this. You want to just make sure you're doing your complete head-to-toe assessment, monitoring for pain, monitoring for signs and symptoms of infection, turn, cough, deep breathe, their labs. Nursing diagnoses. Actually, I'm just going to remove this slide because we don't need that. Urinary tract tumors. This is going to be, it can be a tumor or abnormal growth in any part of the urinary tract. The majority of these tumors are located in the bladder. The least known place is the ureters and urethra. The bladder tumors are seen more often in men than women, more often in whites, and more often in those over 60 years of age. Here's your risk factors. Smoking is a risk factor in most of your cancers. Your pathophysiology, this is carcinogens from cigarette smoke, and certain chemicals are excreted in the urine and then stored in the bladder, which causes an abnormal cell development in the epithelium of the bladder wall. So, in other words, if you're a big smoker or you're around a lot of chemicals, because your kidneys filter everything, those carcinogens move down into your bladder and then they invade the lining. Fat or papillary lesions develop that can be superficial or deep. Most are papillary lesions, which doesn't invade other tissues. Your carcinoma in situ, this is a flat tumor that invades other tissues and has a really poor diagnosis. So your rating, grade 1 is non-invasive. Your grade 3 for your bladder tumors is usually invasive, and it is going to mets, more than likely. Here's some of your clinical manifestations. Colicky pain is just your lower abdominal or flank pain. Once again, here is your diagnostic test that we've been over. Your intervention, if they have surgery, you're going to do your good surgical incision, teaching signs and symptoms of infection. If they have a TURP done, this is a resection of the bladder to remove the tumor. They could have a cystectomy, which is partial or radical, which is removal of some of the bladder. They may require a urinary diversion to make a new way to store the urine. Let's see. A urinary conduit is, this is where the intestines is used as a tube, connecting the ureters to an external collection bag called a urostomy bag. Make sure you know what that is. The cutaneous urinary diversion, this is also where the intestines can be used as a urine reserve to collect urine, which can then be drained with a catheter inserted into a surgically placed opening in the abdomen. You do have pictures of all of these. Let me fix this where you can actually see them. There you go. And then a neobladder. This is just a reservoir. It is made with the intestines attached to the urethra. This will allow for a patient to urinate as if the bladder is still present. It may require catheterization for a full neobladder emptying. So that's all of those three. All right, that is the end. That was short and sweet. Once again, email me if you have any questions, if I have confused you in any way or maybe even misspoken. Don't hesitate to reach out. That's what I'm here for. Please, please, please make sure you're using your extra resources. Thank you.